Thanks for the invitation. I would like to thank the organizing committee to participate in this amazing course. My topic is about the ankle fractures. And ankle fractures, we want to know the common problems. And then we know how to treat and how to avoid complications. Remember, the best advice for these problems is better avoid them. Key for the stability. We want to check the anatomic position of fibula, the status of syndesmosis, and the minimal contribution of posterior malleolus. This is a case we are going to share with you with osteoporosis. This is a patient of 95-year-old, fellow nice, with a closed fracture. He was operated, and this is the operations, always with pain, and the patient was with the movement in the side of the operation. He had pain when walk, and the doctors tried to convince him to operate again, but he never accept. This is the X-ray of the loss of reduction.
How long from the initial procedure? ¿Hace cuánto tiempo de
3 months.
3 months.
3 months.
So 3 months, pain, wounds are okay, incisions are okay?
Yeah.
Okay. And health, body health, general health is okay?
It's okay, but the way he can walk normally,
Okay. So
with pain.
okay.
In conclusion, the care must be taken when treating the osteopenic patients, especially techniques may be needed. We have different instruments to control this bone. The cancellous screw positions, the cortical lag screw, long plates, and supplementary key wires. The cancellous screw is a very good implants to use partially in the threaded screws used in the right side in order to have a better fixation of the plate. Cortical screw allows maximal purchase and may use very long screws and can be cortical if necessary. You see, this is another patient with weak fixation. For the good comminution, we have the comminution is better to have to prepare for the small fragments with plates. We can use screw plates with the small fragment and the bad screw purchase. Also, we can use key wires. Use key with plates and screw. The key wires placed prior to screws and increase purchase of a screw. The intramedullary key wires are good to help to the other implants in order to have a better fixation. In summary, use different techniques with osteoporosis, The ankle fractures can be simple. Be careful and look carefully. Full understanding of fracture is essential. This is another case with fixation. This is the problem. There is very weak fixations, and we have in this case, how can you help me in order to have a better fixation?
So
Do you?
So the problem here, I think, is inadequate fixation, the size, and the reduction. So, Steve, what recommendations would you have for fixation on the fibula for kind of lower transverse fractures?
The transverse, it's hard to get with a screw. Sometimes it's hard to get straight up the axis of the fibula. You can do it sometimes. Some patients not. Sometimes with a fibula, a little hook plate can be quite helpful with the distal transverse component. On the medial side, I'd like to see the side view because I wonder if the transition of the plate anterior posterior might help. And I agree with your reduction component.
In this case, we use the bone graft, for the same patient in order to help for the consolidation of the operation. We had elevated the infection with the use of local bone graft and the subchondral screw. I would like to share with you also the syndesmosis. We have to look carefully at the ankle. How do you see?
So the problem there is just not recognizing the syndesmotic injury.
No.
Yeah.
No.
And the fibula is short and
Sure, that is the problem. The length of the fibula and shortening of the fibula.
So
And
this was referred to you, and then you had to reoperate?
reoperate to,
Yeah.
yeah.
Yes.
You see, short fibula, wide syndesmosis,
Right.
and the talus subluxated, and the patient requires another surgery. You have to restore fibular length, plating the fibula, repair syndesmosis with a syndesmosis screw, and reduce talus.
Go back to the X-ray. Was there a lesion on the talus?
Go the other picture. I guess I wouldn't focus in here.
No, one more forward. Looks like there's a defect on the medial talar head at the corner. Or the lateral.
This is one.
No, next, right there. On the medial talar head, there's a osteochondral
Yeah,
defect.
it's chondral, like a chondral defect.
Yeah.
Yeah. The other thing too is that sometimes when the feet are down, it gives you that talar tilt. And so, if you get the foot up, you get the views. A lot of times it straightens it out.
Key to manage the syndesmosis, to take care of the fibula length, rotations, and open reduction of the syndesmosis. This is another patient, 20 years old. He's a male. He fell from height. And this is the X-ray. The problem? short fibula, failed syndesmosis. 1 year to follow-up with pain. And he requires another surgery. You can see in this case the relations between the fibula and tibia. The problem, white syndesmosis. And this is the reduction and fixed. We need to avoid by stressing syndesmosis. With external rotation, we can check the relation of the fibula. And this is the operation. It is more important to see the screws and the separation of the fibula and tibia. You see the space between fibula and tibia. And now the distance was corrected with these 2 screws. I will show you first.
Do you, on a situation like that, do you open the syndesmosis? If you saw this was referred to?
No, just to screw.
No, so this was sent to you like this, which is not reduced. To get to this point, did you open the syndesmosis or just do a closed reduction?
No, close reduction with the screws.
You don't use a periarticular clamp, just the screws?
For us, it's important not to have a compression between the fibula and tibia, just to have this bone together.
You use the screws to reduce it?
Yeah.
Okay.
We can use screws only or with a plate. We can close with 1 or 2 screws. And there is no necessary to removal unless the patient presents pain. Thank you very much for.
So routinely, you do not remove syndesmosis?
It depends on the patient. There are patients who requires to remove the screw, and there is a patient that has the screw forever.
Do you use the tight ropes for the syndesmosis or always?
No, we can use this kind of device.
Question, when you say you reduce with the screw, are you over drilling the fibula to compress the joint? Or if you do, if the screw isn't in the proper trajectory, do you notice any translation or malreduction?
No compress the side, just to the fixation, to close the sides and fixation of the implant.
No, but he was asking, do you over drill the fibula so it, quote, lags the fibula to the,
Yeah.
so you use a 3/5 screw and you over drill the fibula with a 3/5 drill bit?
A little bit.
Okay.
Thank you very much.